Bismillah ar-Rahman ar-Rahim. Today we are going to discuss the subject of increased destruction of the RBCs, in which we call it hemolytic anemias. The causes of hemolytic anemias are divided into two main categories according to the site of the hemolysis. Hemolysis due to intrinsic factors, which means factors which are present in the composition of the RBCs or the structure of the RBCs. Factors due to membrane defects which result in abnormal influx of fluids and electrolytes through the membrane, making a change in the shape of the RBCs and becoming less deformable, which results in their destruction. Also, enzyme defect, the most common of which is G6PD, اللي هي بتتعرف locally as anemia الفول, and hemoglobin defects اللي هي بتبقى الهيموجلوبينوباثيز اللي هي أشهرهم السيكل سيل أنيميا والثالاسيميا. And there are extrinsic factors outside the structure of the RBCs. These are either immune factors, which means that there are antibodies directed against the RBCs. These antibodies are either formed by another person passing through the placenta from the mother to the child, which we call isoimmune, which may be Rh or ABO incompatibility, or it may be autoimmune. The body itself produces antibodies against itself, whether idiopathic or secondary autoimmune. Other extrinsic factors include non-immune factors. Non-immune factors are, which we call sometimes, are mechanical factors. Mechanical factors is the conditions in which the RBCs pass help their destruction. For example, when we have hypersplenism, they are destroyed in the spleen, or when we have microangiopathic hemolytic anemia, the factors which lead to dehydration, hypoxia, or sepsis, these called activation of a process called DIC, for example, leading to microangiopathy, or microangiopathy means a disease or affection of the small blood vessels, making them more difficult for the RBCs to pass through them, and this is what we call microangiopathies. So what the intracorpuscular or extracorpuscular factors produce their effect, and how do they produce it to lead to the ultimate result of destruction of the RBCs? In the intracorpuscular defects, for example, in the hemoglobinopathies, there are qualitative disorder. The amount of the globin chains produced are normal, but they are defective, as in sickle cell anemia, in which the amino acid leucine is replaced by one called valine. What does it differ when this happens? What does it lead to? It leads to the hemoglobin or the globin chains, when they are exposed to oxidative stress, they result in what we call sickling. Sickling is that it changes into a sickle-shaped RBCs instead of being biconcave discs, which is the normal structure or the normal shape of the RBCs. So the sickling leads to two things: becomes easily destroyed, and also it may cause occlusion in the small blood vessels throughout the body. So these are the two main problems in sickle cell anemia. In thalassemia, there is no abnormal globin chains, but there is reduced quantity of one of the globin chains. In alpha thalassemia, there is reduced quantity of the alpha chains. In beta thalassemia, there is reduced quantity of the beta chains. And this leads that the excess chains, on the other hand, for example, the alpha chains, become deposited on the red blood cell membrane, leading to its damage and denaturation of the RBCs and their increased hemolysis. The other thing that can cause hemolysis, the G6PD. The G6PD, which is an example of the enzymatic defect, causes hemolysis by this enzyme is responsible for protection of the RBCs against any oxidant effect. This protection is not present if the enzyme is defective, and this leads to destruction of the RBCs when it is exposed to this oxidant effect. This oxidant effect may be due to food as the fava beans, for example, or maybe due to drugs as sulfonamides or antibiotics like chloramphenicol. Sometimes it's even due to infection. So the other intrinsic factor is the presence of a membrane defect, such as spherocytosis, the most common, or even erythrocytosis, or stomatocytosis. The spherocytosis, the problem is that we said that before, the membrane is not functioning normally. It allows increased influx of fluids into the red cells, causing them to be in the shape of a sphere. This shape is less deformable. It cannot adjust itself while passing through the blood vessels or through the spleen. Thus, it becomes destroyed in these areas rather than the elastic biconcave disc or the deformable biconcave disc shape of the RBCs. And then we said the autoimmune hemolytic anemias. The antibodies may be idiopathic in the autoimmune hemolytic anemias, or maybe due to collagen vascular diseases or lymphoma, and also it may be isoimmune, not autoimmune, meaning that originating from another person, from the mother through the placenta. And we said also the mechanical factors as microangiopathic hemolytic anemia and hypersplenism. So the increased RBC destruction, or what you call hemolytic anemias, as we have said, there are intrinsic factors and extrinsic factors. And the extrinsic factors may be, as we have said, mechanical, or sometimes they are infections, as Clostridium difficile or malaria, which causes destruction of the RBCs. So when the RBCs are destroyed, what does it lead to? It leads that the body tries to compensate for this anemia by increasing its erythroid production. It increases to a certain extent. It has a certain capacity to do this. So the end result will not complete compensation. Anemia will occur or decrease serum hemoglobin, and the reticulocytes will increase. What are the reticulocytes? Reticulocytes are a precursor of the RBCs, or what we call younger RBCs in development. When we have increased need from the bone marrow, what does it do? It does, like, for example, what anybody arranging a banquet at his home. When we have too many unexpected guests beyond what we are accustomed to, I want to serve them as soon as possible. So I want them to eat as soon as possible because they are beginning to become grumpy. So what do? I take the plate which I'm still cooking, for example, while it is still not completely done, okay? Or what we call here is still a precursor as the reticulocytes to act fast. What can I do else to adjust for this? I don't look for example, similar cups in shape or type because they want to drink as soon as possible. Okay, fill any glass and give it. So there are variety in the shapes. So reticulocytes are increased, variable shaped RBCs. And what else happens when there is destruction? There are RBCs products resulting from this destruction. Iron, because we have the RBCs consists of heme and globin. We have said the globin chains. The heme consists of iron part and bilirubin. The iron part is increased in the blood and becomes deposited in various organs, causing deleterious effects, while the bilirubin is increased When the bilirubin is increased, this subjects them to gallstones and yellowish discoloration of the body, which doesn't look very cosmetically well in older children, but the problem of this hemolysis occurs more in newborns, where it becomes more problematic because here the unconjugated bilirubin has a very dangerous deleterious effect, is that the blood-brain barrier is not well developed, so it can pass and damage the brain up to at a certain level of bilirubin that can damage this brain, causing what we call kernicterus. Then, how we know when we see a CBC having anemia that it is hemolytic anemia? Or when we examine a blood sample, how it is a hemolytic anemia? I see many factors. As I have said, we see increased reticulocytic count and poikilocytosis, but also we see in the blood the products resulting from their destruction or which were present in the structure of the RBCs. The bilirubin increases, the hemoglobin increases, causing hemoglobinuria and hemoglobinuria, and sometimes something is responsible, or a protein is responsible for binding this excess hemoglobin in order to be excreted in urine later on, is called haptoglobin. So this haptoglobin is consumed because it is taken to be binding to the hemoglobin, so we will find low serum haptoglobin. And then we have the iron, or what we call hemosideриnuria, which is increased iron in the blood. As we have said, this will have a deleterious effect by becoming deposited in various organs and increased LDH enzyme resulting from the destruction of the RBCs. Then we will discuss the membrane protein defects which lead to hemolysis. The most common of which is hereditary spherocytosis. It's inherited as an autosomal dominant trait. Autosomal dominant, it does not pass completely from one parent to his child and so on, because some parents are not clinically manifesting by anemia or vice versa. So it has variable penetrance. When we say autosomal dominant with variable penetrance, that the parent may have the condition more severe or less severe and having its laboratory markers, and the picture is more or less severe in the child. This is the most common membrane defect. What happens is that there is a problem of the membrane proteins, allowing excessive influx of fluid into the red blood cell, causing them to be spherical in shape, and then the hemolysis occurs. As we have seen here, it is the RBCs is spherical in shape. As we have said, this spherical shape makes them less deformable, become easily destroyed in small blood vessels and the spleen, leading to the anemia and jaundice as a byproduct of hemolysis, and the spleen becomes enlarged, both due to extramedullary hematopoiesis and sometimes due to hypersplenism. Then we have also, when we examine this patient and see his CBC and blood sample, we have the family history. We have a family history of variable degrees of anemia, and when we look at the smear, we find the spherocytes. So, as we have said, the spherocytes makes the lifespan of the RBCs in the circulation is extremely short. Why is this? Because we have said there is influx of fluids, or what we call the osmotic resistance is decreased in the RBCs. They become more easily subject to influx of fluids even at less hypotonic solutions. So when we do something like osmotic fragility test, we find that their destruction, unlike the normal RBCs, starts at a less hypotonic solution, for example 0.55 or 0.6, instead of the usual ones which occurs with normal RBCs at 0.45 or 0.4. We find the laboratory evidence of hemolysis, and the lysis by something called acidified glycerol test is also increased in time. And we have also, there is a test called usine maleic acid hemolysis test. It becomes also by usine maleic acid more subject to destruction or lysis. So these are many different types to diagnose spherocytosis, because sometimes the yield of the osmotic fragility test alone is not enough. So what do we treat them? We treat them, give them as anemia, we give them blood transfusion according to the criteria for blood transfusion, if it is below 7 or 8, or is clinically manifesting as anemia. And the spherocytosis, because their destruction mainly, or a large part of it is occurring in the spleen, if he remains anemic to a certain age, at 5 years for example, we can do splenectomy, because removal of the spleen reduces in most cases or even cures the process of hemolysis. But why do we wait until the age of 5 years? Because the spleen has an immune function in protecting the body against capsulated organisms like the pneumococcal or the Haemophilus influenzae, and this immunity improves in the body by about the age of 5 years, and thus the body becomes less vulnerable to develop septicemia by these organisms when the spleen is removed. Then we come to the enzyme deficiencies, the most important of which is glucose 6-phosphate dehydrogenase deficiency, or G6PD, or what we call locally as anemia 4. This disorder is X-linked. It is transferred as an X-linked gene from the mother to the child, because you know, when we have a boy, I take an X chromosome from the mother and a Y chromosome from the father. So I become diseased with the G6PD. But what about females? They receive one X chromosome from this side and one X from this side. They are usually not affected because the normal X chromosome is normal and it acts and fulfills its functions. But sometimes there is a theory called Lion hypothesis, in which the normal X chromosome is not functioning very well. So there is a little or some defect to a certain extent when the other one takes over to complete its function, the other X chromosome. So they become affected, but usually they are less affected than males. What is the function of the G6PD? We have said that the function of the G6PD is mainly to protect the RBCs against oxidant products or substances that they are exposed to prevent their destruction. When these oxidants they are exposed to it, the red cell membrane and the hemoglobin become damaged, leading to rapid hemolysis. So what are these oxidant substances? They may be food, as fava beans, and sometimes green beans, or what we call here الفول الحراتي, is very oxidant, has a very strong oxidant effect. And during the periods which people are eating more of this, we have many cases coming with acute severe hemolysis in the hospital. Even if they were mild, they may present at later ages, at the age of 10 or 12 years, first presentation with this acute severe hemolysis. Or there may be drugs as sulfonamides, which are a type of chemobiotics, as we say, and salicylates. Now, of course, salicylates are being less used in pediatrics, except in two things: the rheumatic fever and Kawasaki disease, which is a form of vasculitis, and the chloramphenicol, which is an antibiotic, which used to be used more in the past. Also the stress. Some patients say, I didn't take anything, but the infection stress may lead also to the destruction or the oxidation of the RBCs, of the vulnerable RBCs, also surgery. This leads to severe anemia and pallor, and the hemoglobin goes down in urine, causing red urine. The hypoxemia in the blood vessels because of reduced RBCs may lead to abdominal pain. These patients need immediate evaluation and bringing as fast as possible blood for them. We have seen some patients die because of acute severe hemolysis in G6PD patients where the necessary blood or the parents didn't bring him in the proper time. Then we have the hemoglobin disorders. The hemoglobin disorders, as we know, there are many types of hemoglobin according to the stage of development. There are early the embryonal hemoglobin, then the fetal hemoglobin, or what we call hemoglobin F, which is composed of 2 alpha and 2 gamma chains. And then as adults, we have the main thing, hemoglobin A, which is composed of 2 alpha and 2 beta chains, and at a little extent of 2 to 3%, we have the minor hemoglobin A, or what we call hemoglobin A2, which is formed of 2 alpha and 2 delta chains. As we have said, the hemoglobinopathies may be a problem in the structure of the hemoglobin or the globin chains. It's produced in enough quantities, but the structure is defective, as in sickle cell disease. For example, sickle cell disease, something only the leucine is replaced by another amino acid, valine. This only minor defect results in that the RBCs, when they are exposed to hypoxic effect or any factor causing hypoxia, or sometimes in severe cases, maybe spontaneously, they become sickle-shaped. This sickling, as I have said, becomes more vulnerable to destruction in the small blood vessels and the spleen. And also, it is a factor which may cause obstruction of the small blood vessels, or what we call vasoocclusion, and we will discuss later how this is deleterious to the whole body. And there is a quantitative property in which the globin chains are produced at a reduced amount. For example, in alpha thalassemia, the alpha chains are decreased, and thus the beta chains are in excess, and the opposite in beta thalassemia, in which the alpha chains are in excess, become deposited on the RBC's membrane and causing its damage and destruction of the RBCs, sometimes even a very early destruction in the bone marrow, what we call ineffective erythropoiesis. So, when we discuss sickle cell disease, it's an autosomal recessive genetic abnormality which is passed when both parents are carriers for the gene for the hemoglobin S. As we have said, the amino acid is replaced or encoded from glutamine to valine, and this causes the hemoglobin or the hemoglobin S to be changed into a sickle-shaped RBCs when exposed to hypoxic stress. They are long, rigid rods. They become destroyed, and the sickling or the sickle-shaped can cause vasoocclusion of the blood vessels. Why the sickled RBCs cause this? Because they cannot pass through the small blood vessels. They may cause acute hypoxia, thrombosis in different areas of the body, infarction in the brain, myocardial infarction, vasoocclusion, bone infarcts, and also the sickled RBCs are fragile, as we have said, thus leading to hemolysis and a picture of hemolytic anemia. Its incidence is more in the black population than any other populations. It also occurs in populations from the Middle East, here in Egypt, in Saudi Arabia, in Turkey, in India. As we have said, we have the vaso-occlusive crisis. The vaso-occlusive or infarctive crisis, because it kills, infarction is a necrotic tissue or necrosis in the tissues. What does it precipitate? Anything that leads at the end result of hypoxia. For example, cold exposure, vasoconstriction, hypoxia. High altitude, less oxygen, hypoxia. Dehydration, reduced fluid and delivery of blood with oxygen to the body. And also infections may cause this. What happens if it is in the bones? It presents as pain in the bones, mainly the tibia and the back and the joints and the muscles. Sometimes it affects the chest, including the lungs, causing acute chest pain, and the abdomen, the mesenteric vessels, causing acute abdominal pain, or maybe mesenteric vascular occlusion. Also, hemolytic crisis occurs. There is rupture of the sickle cells and the hematocrit falls, and jaundice occurs, maybe even gallstones. What else other than the hemolysis may happen? First, we have a real problem or a severe problem which is called the sequestration crisis. What means sequestration? Sequestration means that the RBCs and blood become entrapped in the spleen because of their sickle-shaped acutely. This causes that they are destroyed in a massive amount in the spleen, huge splenomegaly, and the circulation is deprived from a large amount of its fluids, causing hypovolemia and shock. If these patients are not managed very rapidly by blood transfusion of normal RBCs to reduce and facilitate the breaking of this entrapment in the spleen, they die very rapidly, and it is a highly dangerous process. Also, we have a plastic crisis. As we have said, the bone marrow is very important for replacing the hemolyzed RBCs in any hemolytic anemia. So, when we have suppression of the bone marrow due to any cause, transient cause, even like parvovirus B19, we have a defective bone marrow and increased hemolysis. We have a severe anemia and a life-threatening decrease in hematocrit. So what the lab shows in sickle cell anemia, we have normocytic anemia, not microcytic like the thalassemia, and we can identify the hemoglobin S or this defective hemoglobin in hemoglobin electrophoresis, and we can do also prenatal testing for the defective genes. Sometimes it is done or requested by the patients by chorionic villus biopsy at the age of 10 to 12 weeks for early diagnosis, because some families and many religious clerks have allowed the termination of pregnancy if the coming offspring is diseased. So, other complications also, acute respiratory insufficiency. This may result because of two things happening. Infarcts in the lung because of the vaso-occlusion process which is happening in the lung. There is also thrombus may occur, such as pulmonary embolism, which may cause lung infarcts and collapse. And pneumonia is facilitated also by this problem. What we call here is acute chest syndrome. Also, the vaso-occlusion in the CNS may result in having transient ischemic attacks coming and going before causing the complete obstruction and brain infarct, maybe even with disturbed conscious level and hemiplegia. And sometimes the obstruction promotes with it the development of brain abscess because it's an infarcted tissue, and this the organism coming because he is more susceptible to infections, this sickle cell anemia patients, because the spleen is defective. So the infection and the infarct leads to the production or the development of a brain abscess. There are also the complications having in the musculoskeletal system. The complications in the musculoskeletal system may include joint pains, muscle pains. More severe, there are necrosis happening first in the femoral head. This necrosis in the femoral head may necessitate joint replacement. It's a serious complication of sickle cell anemia. There may be swelling of the joint, arthrosis or arthritis. Also, like the brain abscess, if we have increased susceptibility and exposure to a bacterial organism, septic arthritis and osteomyelitis may occur. And then we have a complication with the priapism. The priapism is sustained erection of the penis more than 4 hours. This happens in sickle cell anemia because the blood goes into the corposa cavernosa and does not easily come out because of the sickling in the RBCs. It becomes entrapped. This continuous entrapment of the blood in the penis presses on the blood supply of the penis and may result in penile necrosis and infarct and even gangrene if it persists more than this. Also, complications may occur in the kidney. There are vasoocclusion in the renal blood vessels leading to a renal infarct, acute cortical necrosis with the resulting flank pain and hematuria, and this poor child becomes repeatedly exposed to intake of narcotic drugs to soothe his pain or continuous repeated pain, so he may need higher levels of pain relieving, including narcotics, tramadol. So the management of sickle cell disease first begins with the simple measures. These simple measures, like giving antibiotics for prophylaxis against the organism, which he is more susceptible than other persons because of, as we have said, the splenic infarction and the decreased function of the spleen caused by the splenic infarction in sickle cell anemia. We know the spleen has a function in protecting us against encapsulated organisms, so they take penicillin prophylaxis since very early ages, now advising by the age of 2 months to start the prophylaxis, to receive folic acid in order to reduce the relative folic acid deficiency resulting from increased work or RBCs production by the bone marrow. And there is general treatment if he has anemia or pallor or repeated blood transfusion. We may need to give them blood transfusion on a regular or even variable level to reduce the tissue hypoxia, but not to give blood transfusion above, but not to give it to bring it to higher levels, for example above 11.5 or 12, because this increases the viscosity of the blood, and while it fixes the anemia problem, it may cause more vasoocclusion. And there are specific problems which we have to deal with. First, the treatment of iron overload, which is present in sickle cell and other chronic hemolytic anemias. If it becomes above a certain level, we may have to give iron chelators to reduce the risk of deposition of iron in the different organs of the body, the heart, the endocrine glands, the liver. And there is specific treatment also for the different complications which occur in sickle cell. If you have acute chest syndrome, you are giving antibiotics as macrolides and oxygen support and blood transfusion. We may need, if this does not work, exchange transfusion. This is also needed in we have a stroke. We may need also exchange transfusion, and later giving a plan of chronic blood replacement for the sake of keeping the blood always below hemoglobin S below 30 and this reduces the viscosity on the long term and helping to avoid the happening of stroke again. Also, within the preventive therapy, we may need to do repeated Doppler assessment in order to discover preemptively any problem with the carotid and cerebral blood vessels that may necessitate intervention with the transfusion program. We may need intervention for any vaso-occlusive crisis when they occur regularly or more than 3 times per week. We may need to give some of the hemoglobin F inducers we are going to discuss in order to reduce this. We may need to give treatment for osteomyelitis, antibiotics, and in case of priapism, we may need to do transfusion or exchange transfusion or even aspiration or drainage of the penis before gangrene happens. As we have said, the newest or the new areas which we are looking now in sickle cell anemia is mainly in hemoglobin F inducers. We try to increase the hemoglobin F, which has become not working like before at the end of pregnancy and at the beginning in the first few months of life, to try to induce it to increase its production to compensate for the abnormal hemoglobin S which is produced, and increasing its ratio to the hemoglobin S so that the hemoglobin S percentages become less, the blood less vulnerable to hemolysis and less vulnerable to cause vaso-occlusion. There are other products than the hydroxyurea they are working on at the present time to give these effects without causing many side effects which are caused by the hydroxyurea. There is a gene therapy replacing the defective gene, but this needs some time to work. And bone marrow transplantation, if the patient is having a HLA matched sibling, we can transplant it to the sickle cell anemia patient, especially those which are having recurrent problems. The results are actually very promising, but the patient has to be free from any organ dysfunction in order for the bone marrow transplantation to give or to work well. Then we come to the thalassemia syndromes. We have said that the thalassemia is a process in which there is normal production of the globin chains, but they are reduced. So there is imbalance in the globin chain production. It is inherited in an autosomal recessive way. Both the mother and the child are carriers. When there is an excess alpha or beta chains, it's deposited on the membrane, causing denaturation of the RBCs and its destruction. The destruction occurs in the blood, the spleen, maybe even early in the bone marrow, in which we call ineffective erythropoiesis. We don't even produce it into the blood, and sometimes the retics, even the hemolytic anemia, are not very high like other hemolytic anemias. And the peripheral blood smear in these patients show severe hypochromic microcytic anemia, like this present in iron deficiency, but there are certain differences between them. These differences, there is a red blood cell distribution width which is increased in iron deficiency, and also the number of the red blood cells are being less in iron deficiency. And then when we do test the hemoglobin electrophoresis, we find a reduced amount of hemoglobin A production because we have reduced beta chains. This in beta thalassemia major. The bone marrow tries to compensate, causing erythroid hyperplasia. The erythroid hyperplasia, the expansion of the bone marrow, cause skeletal deformities in the form of expansion of the maxilla, as we will see in the next picture, and the upper central incisors. If it is working excessively, the bone marrow, it causes this forms, but if he is transfused regularly, the expansion of the bone marrow is less, and these deformities are less, and there are extramedullary hematopoiesis, giving splenomegaly, and hepatomegaly. As we can see here, we have this prominence of the maxilla. We have protruding upper central incisors, and we have a prominent forehead, and we have also macrocephaly. This, as I said, if they are not transfused well, there is excessive expansion of the bone marrow, but we always try to infuse them well or give them blood transfusion in the proper times they need in order for good functioning of the tissues and reduce the cosmetic problems. So, the complications, of course, there is chronic tissue hypoxia. This causes growth retardation and deposition of iron in the different endocrinal glands, for example, in the growth hormone deficiency because deposited in the pituitary, this contributing to the growth retardation he is actually having, and deposition in thyroid causing hypothyroidism and maybe diabetes at older ages above 10 years. This iron or systemic iron overload may be deposited in the liver, leading to liver fibrosis and cirrhosis, and deposited in the heart, leading to heart failure and arrhythmias, which is the main cause of death at the age of second or third decade. In the CBC, we see microcytic hypochromic anemia, and the hemoglobin electrophoresis, we can see the increased hemoglobin F, which is present, and we also increase or have decreased hemoglobin A, and we may test for the defective genes by DNA analysis, which may allow for prenatal testing in order to help if the parents require to prevent having a child with thalassemia to do termination of pregnancy at the age of 10 to 12 weeks. Management of thalassemias, we need to give frequent blood transfusion because they found that in the ratio of 8.5 to 10.5, the body is supplied by enough oxygen which it needs for its growth, for his normal activity. So we try to transfuse them at these regular intervals. Iron chelation to avoid its deposition, we have said, in the endocrinal glands, in the pancreas, in the liver, in the heart, and splenectomy if the spleen becomes markedly enlarged, causing breathing problems for the child because of the significant abdominal distension, or becomes hyperactive in destroying the RBCs, contributing more to the problem of hemolysis. We may remove it, but as we have said, better wait until the age of 5 years. The gene therapy, this also needs some time to work, and the bone marrow transplantation, if we have an HLA matched sibling, which is actually producing marvelous results, and we have implanted many patients here in our bone marrow unit. Of course, the results are better if the child is younger and if he has been properly chelated before coming to the transplantation. So, about the chelators, we have three known types of chelators. We have first the earliest one is the deferoxamine, or what we call desferal, the trade name. This one is parenteral. It's given either subcutaneously or intravenously. It has to be given over 8 to 12 hours because this constitutes proper chelation, because its half-life is very short, so it needs to be given over 8 to 12 hours to expose it as much as possible for the longest period to the iron which is present excessively in the blood. So they do this by the infusion pump at home, put it subcutaneously. We will see in the next picture, 5 days a week. I've said the half-life is very short, 20 to 30 minutes, and the main adverse effects, local reactions or allergy, but there are in high doses ophthalmologic retinal toxicity or auditory toxicity and hearing affection, maybe even growth retardation. We have the deferriperone. It's an oral drug which is given 3 times per day, having a half-life of 3 to 4 hours, thus needing to be given 3 times per day. It's having, although it is oral and more convenient and more compliant than the injectable form, but it has a little bit more side effects in the form of nausea, vomiting, affecting the liver enzymes, and maybe the serious problem of reduced neutrophil counts, which may subject the patient, if left unmanaged, to having serious infections. And then the most recent is the deferasirox, which is given once daily because it has a longer half-life, 8 to 16 hours. It's convenient because it is oral and once per day, and having a little bit less side effects than deferoperone. It's mainly in the form of gastrointestinal disturbances, mild and non-progressive creatinine increase, or the proteinuria, or even elevated liver enzymes. As we see here are the infusion pumps. The syringe containing the Desferal is put in this infusion pump, and then coming a subcutaneous tube, which is put subcutaneously around the umbilicus in a subcutaneous form. Maybe the child is sleeping. And this concludes our discussion of chronic hemolytic anemias or hemolytic cases in children. Thank you very much.